Welcome to Eye Contact. I am José Güell. We are talking with Dr. Boris Malyugin about intraocular surgery in the short eye. Welcome, Dr. Malyugin. Welcome, Boris.
Thank you.
Short eyes present a number of challenges. What should we be thinking in the preoperative stage with these patients?
Short eye is quite a broad definition, so we have to distinguish what kind of short eye we are talking about. And we know that there are three major types and variation. First is the microphthalmos. Microphthalmos is when the anterior segment of the eye is pretty normal, but the eye is short. Second is when the patient is having relative anterior microphthalmos, meaning that the anterior segment of the eye is reduced in dimensions. And the third one, which is the most complex, is nanophthalmos, when the anterior and posterior segment are both reduced in size, and there is a thickening of choroid, and there is a thickening of sclera, and these are the eyes that presents the most significant challenges for the surgeon.
And each one of them needs different surgical tips for managing.
Obviously, yes. Obviously, yes. And for instance, for nanophthalmos, you have to look for choroidal effusions or suprachoroidal hemorrhages, because for malignant glaucoma that may happen after the surgery as a postoperative complication. So this is a really, really challenging eye, and we have to pay special attention to preoperative examinations in order to distinguish in between all these three variations.
And many times consider possibly a general anesthesia for these eyes, no?
Oh, absolutely, absolutely. You want to avoid the congestion of the episcleral veins that may happen with the peribulbar or retrobulbar injection. You don't want to avoid the pressure that may cause on the posterior segment by anesthetic. So that's why you be very careful. And of course, you need to carefully counsel these patients, because you have to warn them in advance that these are the challenging eyes, that there are possible issues that you may face, and you have to sometimes need the secondary surgery. So the patient have to be fully aware about the complication they may have during the surgery.
And you will be particularly ready also. We all are particularly ready, because sometimes we need to do core vitrectomy or something to improve the conditions of the eye at the time of the surgery, isn't it?
Obviously, obviously, these are the eyes for expert surgeons.
Yeah. Okay. Okay. And what about IOL calculations? Any tips? Any particular tips? Although possibly, as you mentioned, tips would be or will be different depending on these three groups that you nicely described. But any tip?
Of course, we need to use optical biometry in all of these cases in order to make calculation. It was a nice publication that came up recently in Journal of Cataract Effective Surgery, comparing 9 different formulas in different eyes. Including short eyes, and it was interesting for me to read that the Olsen and Hygis formulas performed the best out of the all formulas. So I considered it a bit different before, but now I'm more and more using these 2 formulas in order to calculate this lens with having a very good result.
Me too, with the highs. What about during surgery? What complications should we most concerned about in general? No, I understand that, or if you want to divide in different groups, but which are the most important complications we need to deal with?
When we are manipulating in a small eye, so actually you have a limited space for your instruments, so you have to be quite careful and delicate in your maneuvers. And of course you have to use heavy viscoelastics in order to maintain space. So you have to carefully think about all the steps of the surgery. For instance, incision. Incision, when done very close to the iris root, will give you the tendency for the iris to prolapse. And in a small eye, it's a big issue. So your tunnel should be longer, and in some cases much longer than you may usually do in the regular patient. Second is given the shorter anterior chamber, so you have a high risk of damaging endothelium. That's why you need to be careful and work below the plane of the iris in order to avoid that issue.
And this is also very common, as you know, because you are an expert on that, that pupils are not the desirable size, so you frequently need to deal with pupil size at the time of surgery. And again, any trick, Boris?
Of course, the trick is to use intracameral phenylephrine. We know that it is a very effective tool, and we do have commercially available substances that we can use now in Europe. Also, you may consider at some point using a pupil expansion device in order to expand the pupil and hold it in place.
And it's I am one of the defenders of your Malyugin cream, but in some of these cases might be difficult to use it, isn't it?
Absolutely. For instance, in microphthalmos, when the anterior segment having more or less regular dimensions and only the posterior segment is reduced, I will be not hesitating in using the Malyugin ring. However, in non-ophthalmos or relative anterior microphthalmos, the situation is different because the anterior chamber is quite shallow, so you want to avoid placing any additional device inside the anterior chamber. So these are the eyes where I definitely consider using iris hooks rather than any kind of iris expansion ring.
Thank you very much. Thank you very much, Boris, and thank you all for joining us. For more information, visit us at eurotimes.org.